Yeah, the KEYNOTE-057 cohort B study was a single-arm phase 2 study investigating multiple cohort of patients with high-risk non-muscle invasive bladder cancer who were unresponsive to BCG. The cohort A of the study included the carcinoma in situ component with or without papillary tumors and resulted in a CR rate at 3 months of 40% and a median duration of response of 16 months. And this data resulted in FDA approval of Pembrolizumab Monotherapy in this patient population in the post-BCG setting. The results that I presented at this meeting are relative to the cohort B of the study. That is, including patients without any CIS component with only papillary PTA or PT1 disease. The primary endpoint for this cohort was a 12-month disease-free survival rate for high-risk disease. And the study provided a rate for a disease-free survival of 43% at 1 year, which was compelling. Also considering the fact that the safety data were consistent with the data already available with Pembro monotherapy in various disease settings, including cohort A of the study. And there were no new safety signals, no treatment-related death, and the stability in quality of life parameters was observed in patient continuing treatment without progression. So the results are basically setting a potential expansion or indication of pembrolizumab in patients with non-CIS population. It's a great question because as of today, we do not have a consensus for the treatment of, at least as intravesical therapy, standard intravesical therapy for patients with, in particular for patients with papillary tumor unresponsive to BCG. There are data and supporting the use, for example, of chemotherapy options that is currently used in the United States, much less in the European Union, but there is still no agreement, and there is still difficulty in identifying a standard of care arm towards which compare any newer therapies in this patient population. So this is the difficulties nowadays of identifying a right design for a randomized study. I think that there may be room for discussion. I think that this data may generate, may reinvigorate a discussion towards the right and the optimal trial design to conduct in this patient population of papillary high-risk disease, BCG-unresponsive disease. As I said, randomization, and the FDA is requiring randomization is a good thing to adjust for multiple potential bias, mainly related to the TURBT quality. But as already mentioned, the primary issue when dealing with the randomized studies is the identification of a standard of care arm towards which randomize any newer therapy. And for practical reasons, I think it is becoming more and more difficult to provide and to offer this patient population a trial option that is including a randomization towards standard of care based on the movements of newer therapies that are ongoing in this setting.